Thanks for joining us. Guelph, Ontario. Emily's. Welcome. Where else are you all from?
Newcastle, England.
We'll just wait another minute, let everybody in. Cool. Welcome back, Susanna. From Germany, Santa Cruz, California, Cape Town. Wow. Is that Cape Town like South Africa, Cape Town?
Presume so.
Wow. Yes.
Yeah.
Holy smokes.
What time is it in South
I was just thinking that.
Sarah, Colorado.
Hungary. Claire's originally from Cape Town. Wow, small world. And now you're in Pasadena, California.
Oh, 8:30 p.m. Okay, so you're only an hour ahead of the UK. Interesting. My geography must be really bad because I didn't predict that.
You're like, it's all the way over there.
Yeah. Oh no, I'm really sorry. I like animals' brains. What can I say?
Not geography. Okay, so let's get started. Welcome to our final of the 4-part series, Brain Rewires the Brain. Pain rewires the brain. And the focus today, the lens we're looking through is reactivity. And I'm very excited to have Dr. Kathy Murphy with us today as we close the series and put it all together. I'm here in the chat. If you guys need me, please, if you have any questions, put them in a chat. If she doesn't answer them throughout the presentation, we'll make sure to get to them at the end. Take it away, Dr. Murphy.
Okay. Pain rewires the brain, reactivity. Okay, so I guess the first thing we ought to do is think about what reactivity is. And I'm not going to give you any magical answers to that. I mean, what I'm meaning when I talk about reactivity is essentially just encompassing an active coping strategy. So that could look like lunging, barking, hypervigilance with some motor reactivity, motor reactivity being separate from cognitive reactivity, but sometimes looking identical when the dog's on the end of the lead, for instance. So yeah, it could encompass a whole different variety of behavioural phenotype, but also obviously the cause could be very different. So, I mean, the animal could be frustrated, could be associated with aggression, it could be associated with prey drive. So yeah, I'm not going to solve that issue for you. And I know that some people like to use sensitive as a word to replace reactive when talking about dogs, because that tends to speak to it talks about the subject in a more compassionate way, and speaks about the subject rather than about the behavior itself. But whether you sit in the camp of the terminology of sensitive or you sit in the camp of the terminology of reactivity, it is still a very popular term, especially used by owners. So yeah, that's what we're encompassing in today's. Now, the fact that we can't pin that down in terms of either motivation for that phenotype or the different behaviours that it might compose of is actually perfect for the end of this series, because what we're going to talk about today is going over the relationship between physiology and psychology, so that intermesh. And pain is actually the perfect example of an intermesh between physiology and psychology. So it brings together a lot of the principles that we've already discussed in the previous lectures, but using the reactive dog to kind of explain those principles gives us a slightly different angle on it, which I hope means the aim of today is to bring everything together and bring it to a kind of logical round conclusion that leaves you in a position to then go away and think about your cases in a slightly different way, and to understand I guess why we need to address pain urgently in behaviour cases. Okay. Oops. Yeah, there we go. So just to recap the effect of pain on behavior, and I've just realized that I didn't fix my animations, so I'm just going to run through them. So we've seen this slide a couple of times before, but just to recap in terms of reactivity, we could have a direct effect of pain on reactivity. So we could have an animal that is acting in that way in order to protect itself from injury or disease. And you can think quite logically about that. If I'm out in the world and I'm in a busy park, I may well decide that lunging and barking is a quick way to create distance between myself and the stressors, and therefore I'm likely to protect myself against injury or disease. Obviously, in the case of reactivity, as with the case of aggression, sometimes that can involve physical exertion, and that in and of itself can make the pain worse. So you can get trapped in a vicious cycle, but it's not a vicious cycle that the animal would naturally break for themselves, because any pain associated with that physical exertion usually is delayed. So you get delayed response to the physical exertion. And actually, yeah, for some strange reason, my PT was talking to me about that this week in the gym. And yeah, it was just reminding me that it's directly relevant to what we're talking about when we talk about pain and animals' behavior as well. So pain could be having a direct effect on reactivity, but it could also be an underpinning factor for reactivity. So the behavioral signs of pain could be subtle or even absent, as we talked about before, or compensated for. So they're there, but most of the time the animal can compensate for them. Or they're simply just thought to be unrelated to the reactivity. And partly that depends on the timing of each of those and whether there are signs of pain or not. But it could be lying there as an underpinning factor. It could be exacerbating pre-existing reactivity. So this obviously is very common because if the animal has a tendency towards reactivity, or in this case, we're really talking about dogs when we talk about reactivity, but if the dog has a predisposition to reactivity, then pain could exacerbate that for all of the reasons that we previously discussed. And we talked about the fact that you can see changes in emotional processing, so irritability, increased stress reactivity, decreased resilience, increased hypervigilance. All of those are directly relevant when we're talking about reactivity phenotypes. Pain could also be having an adjunctive effect. So that could be a shift in coping style. And this is particularly pertinent to dogs with reactivity, because what can sometimes happen is that dogs, before they encounter pain, have a passive coping strategy, but they actually shift their coping style in response to pain to an active coping style. So in those cases, it can seem like quite an abrupt onset of reactivity for no apparently good reason. And that's simply because the coping style intensity may well be the same, but because the coping style itself is shifted, you've now got behaviors that you've never seen before in that dog, or you don't recognize as that dog's normal response to stressors out in the world. So it might be a dog that usually would just come to you for social reinforcement and would be passive in the presence of stressors, but now is reactive in the presence of stressors, and that switch happened relatively quickly. Oops. Yeah, I don't know what's going on with those, sorry. So one thing I thought might be quite useful at this point is to just go through the different sources of pain. And this is by no means an exhaustive list. And there are lots of different resources for you to look to delve into this in more detail. We'll have more resources next year, for instance, but there are already more resources in the Behaviour Vets library and also in other libraries. But we want to think about different areas. So we've got ear disease and dental disease, both of which are extremely common. Ear disease is particularly common in certain breeds. So you may have a breed predisposition. Dental disease is particularly common at different life stages. So obviously when the dogs go through teething, and then later in life as dental disease onsets. And then also in particular breeds, you're more likely to get dental disease. I actually have a very good friend who is a veterinary dentist, and I learned quite a bit from her. And one of the things that I really took home is that you can have an oral cavity that looks perfectly and utterly healthy, with no tartar, no gum disease, and perfectly solid teeth. But when you x-ray that, you've got dental disease in the roots below the gums, and that dental disease is associated with pain in humans, and it can be associated with behavioural change in animals or dysphagia, so the dropping of food, etc. So it's thought to be of a similar profile to humans, i.e. That can cause pain well before you can see any signs of dental disease. So it's not enough to just simply look at the oral cavity. You need to have a proper dental examination in order to determine whether there's pain there, and then potentially go on to do dental x-rays. So for any disease around the head and the neck area particularly, you're going to be looking for things like facial symmetry. So whether the face looks symmetrical, that's literally all it means. Whether there are any changes to the way that the face used to look. And sometimes it is actually useful to look back at previous photographs to see whether there are any changes, particularly in pinna symmetry, so that's the ear position, and whether or not you've got asymmetrical changes to the ear position, or you've got symmetrical changes to the ear position. But ear position can be one sign associated with pain, particularly associated with head and neck pain, but also actually associated with pain in other areas of the body. And dysphagia would be logical for dental pain, but actually interestingly also for some types of ear disease, because if the pain associated with the ear disease is in the middle ear, you can get dysphagia associated with that, because every time the jaw moves, the temporomandibular joint moves, and that changes the pressure within the ear canal, so that can be associated with pain. You've got your cervical area, which is the neck area. So you've got a whole range of diseases that could occur there, like disc disease. You could have injury. So I had a Belgian Malinois who'd been an ex-police dog, and as a result of some of her bite work, she had a neck injury. You could have congenital problems there. Obviously, some breeds are particularly predisposed to that. And you're going to be looking for things like willingness to move the neck, symmetry of the neck muscles, also relative heat in the different areas of the neck, coat pattern changes, and that's not just for the cervical area, but actually for any area. It's really interesting to look and see whether you've got any swirls, any changes of direction of coat pattern, any changes of density of the coat, and also sometimes the colour of the coat and the shine of the coat. I haven't got them here, but in a previous webinar I've shown slides of my Rottweiler, and you can see the progression of her arthritis, because her coat became very swirly, and she has a very shiny coat. So she used to have a shiny coat that all laid in the same direction, and as her arthritis got worse, she got more and more curly. And then when I put her on, I found an analgesic that suited her. We had to go through several analgesics, but then I found an analgesic that suited her, and after being on that particular analgesic for a couple of months, and the coat flattened back out again. So these are subtle signs, and often signs that the owners won't notice, but they will kind of recognize them if you say, has this swirl always been there? Has the coat always been curly over this area of the spine? Have you always had a wave in the coat here? Owners will usually be able to remember whether that is the case or not, and if not, just look back at photographs of when the animal was young. Muscle tension, and that isn't just limited to the cervical area, but you want to be feeling for relative muscle tension, and also to the response of the muscle to light touch, and then perhaps to more pressure, being careful obviously to make sure that the animal doesn't mind being touched. And here, just as a disclaimer, obviously if you're a veterinary surgeon, you're going to be able to do these examinations in some detail. If you're not a veterinary surgeon, then you're not making a diagnosis, but there are still signs that you can pick up on. So the coat patterns, the symmetry, etc. And even to some extent the muscle tension, because you can do that without inducing pain, as long as the dog's not obviously painful. But we're assuming here we've got a case that's presented with behaviour, and the owners aren't aware that it's in pain. And so as you're stroking the dog, then just be super aware that you can collect information whilst you're stroking the dog. So you can collect information about whether the dog, turns its head round when you touch on a particular side, and obviously then don't keep repeatedly touching that side. Or if the dog moves away from your hand, particularly common when you're touching the back end, and that may well be particularly common because we have arthritic change there commonly in dogs. Skin movement over the muscle also. So again, if you're stroking the animal or in physical contact with the animal or providing social support for the animal that involves physical contact, just be aware of how easily the skin moves over the muscle. You've got fascia joining the skin and the muscle, so that's another layer of tissue, and that tissue type is different. Fascia is hugely innervated, and it also changes, stretches and compresses according to different muscle tensions and according to pain. So that changes the way that the skin moves over the muscle. So that's why it's so important for a pain exam to actually be looking for that, to look at how easily the skin glides over the muscle. Because if you've got an area where the skin doesn't glide as easily over the muscle, or it starts twitching instead of gliding over the muscle, then you may well have fascial changes there, and that could be an indication that that's an area to look at in more detail. And things like avoidance of equipment are quite common with cervical area pain. So, avoidance to have the collar on, avoidance to have the harness on, etc. Now, you've obviously got a whole range of orthopedic pain, and I'm not going to go into that in any detail because you can look on the Canine Arthritis Management website and also their Facebook page. They've got a huge amount of free resources, like an unbelievable amount of free resources. So if you haven't found that resource, Canine Arthritis Management, please do, because it's amazing, and it will go through in great detail about all the different sources of orthopedic pain, and indeed all the different sources of muscular pain, and how different specific muscular pain can relate to different orthopedic early stage, different orthopedic conditions, and fascia. So you'll find a huge amount of resource for all of those. We mustn't forget soft tissue, so visceral pain, things like gastrointestinal pain, ulcers, and you might see excessive gas, you might see a bowel posture commonly presented. So, sometimes owners say they might be presenting for something else like separation anxiety, but they'll say, no, he often sits in that funny bowel position. It's really cute. I often hear that, particularly with brachycephalics. You'll often hear the owner say, it's really cute, he does a bow. Well, we know that brachycephalics are very prone to regurgitation and to gastrointestinal ulcers. And we also know that the bowel posture is associated with abdominal pain or gastrointestinal pain. So even though it might be what they normally see, it doesn't mean it's normal. And it could mean that the animals had it from a very, very young age. So they may never have seen their puppy, now grown into an adult dog, not doing that behavior frequently, but that doesn't mean it's normal. It's not a personality quirk. It could potentially mean that there's gastrointestinal pain. And then obviously any animal that presents with a history of fecal abnormalities, so things like dietary sensitivities, whether that's a true sensitivity or not, intermittent diarrhea, intermittent constipation, changes in colour in stools, all of those things. So even though as a behaviourist it doesn't sound like information that should be for you, actually it can be important for you to be asking those questions about diet and feces, because you can get a lot of information about how physiologically normal this animal is, or how physiologically stable this animal is. And obviously the vet won't know that unless the owner presents the animal to the vet. And if they're coming to you for behaviour, it may well be because, they haven't gone to the vet because they don't think there's any reason to. You've got bladder cystitis, so behavioural changes associated with cystitis are fairly common, and anyone who's had cystitis will understand why, because it's unbelievably painful. Prostate in male dogs, obviously the same, and you might have a history of urination changes to frequency, straining either for urination or defecation in the case of the prostate, etc. And skin disease. So skin disease in and of itself can be painful, but skin disease also is associated with chronic inflammation, and chronic inflammation can be a predisposing factor for chronic pain. So if you have skin disease already, it can actually make pain in another area worse, so that where it wouldn't have been painful before, it is now painful to the extent that it's causing behavioral changes. So you've got that kind of exacerbation, if you like, of a pain condition by a skin condition. So skin can be important for that reason, but skin can also be important in terms of looking for things like coat pattern changes, changes in just general coat condition can give you an indication that there might be something else going on. It might not be pain, but there may be some other disease process going on, etc. So condition, also the sensitivity of the skin. And that's something I think that we really struggle to determine in a veterinary consult, because it's very unlikely that the animal's skin will be sensitive in a veterinary consult, unless it's extremely sensitive. But usually, because they're full of adrenaline and cortisol, whether that's excitement or fear and anxiety, they usually won't respond in the same way to light touch as they would in their home environment when they're relaxed. So again, that's something that's really important for a behaviorist and or trainer to be assessing in their home environment. Don't be weird about it. Dogs get super freaked out if you're weird about touching them. So it's more a case of training yourself that during the normal course of interacting with the dog, when there's an opportunity for physical contact with the dog that doesn't stress the dog out, to be looking for that information. So to be not just, saying, oh, we're having a cuddle, but to actually be thinking, oh, am I seeing any twitches in the skin? Is there any shine away from the hand? Does the animal seem to be responding to pressure the same all over? So it's about training yourself to collect that information. Okay, so that still doesn't really explain why some dogs develop chronic pain and some dogs don't, because we know that some dogs with some of those conditions will respond to analgesia and not develop chronic pain, or actually don't need analgesia and will have those conditions, not receive analgesia and still not develop chronic pain. And yet for some dogs, chronic pain becomes a real problem and can be, become maladaptive essentially. So that's when chronic pain moves into that maladaptive state. So why is it that some dogs, and this isn't just dogs, this is animals, so why is it that some animals develop chronic pain and some animals don't develop chronic pain? And what are some of those factors? First secret word is chain. So that's chain for the first secret word. So looking at the incidence of chronic pain in humans, it's very difficult to get any incidence of chronic pain in animals because we essentially don't recognise chronic pain very well in animals. And certainly surgeons don't recognise chronic pain in animals. If you're a surgeon and you're on this call, and huge apologies, but you can't deny, in fact, the literature shows that as a micro specialisation, or as a specialisation within veterinary medicine, surgeons are not as adept at being able to spot the signs of pain as, say, anaesthetists or general practitioners. So, yeah, it's very difficult to get accurate information about the incidence of chronic pain. But if we look at the human studies, we see that the incidence varies greatly, and it varies depending on the type of the cause of the chronic pain. So if we look there, 18% incidence for neck pain, as compared to 48% incidence for diabetes. Well, those are two completely different conditions that have completely different pain profiles. And actually, in the case of diabetes, you've very likely got an inflammatory process at the same time as you've got neuropathy. So the inflammatory process will increase the incidence of chronic pain developing, etc. So you've got a much more complex pain profile than perhaps you've got in neck pain, for instance. But you can see there's a whole variety of incidences there. So you've got different pain profiles according to different causes of pain. You've also got different patient populations, and that's probably even more important when we come to thinking about different dog breeds, because if you think about different patient populations for humans, we're really only talking about different life stages and then different races, so different genetic lineages. But when we're talking about animals, we're talking about different species, then we're talking about different breeds, and then within breeds we've got different genetic lineages that may or may not have different sensitivities to pain, and obviously may or may not have predisposition for different types of pain developing with different conditions. Different species, which we've said, and then we can't forget different study designs. So we still don't know how to categorize the incidence of chronic pain in humans, simply because the study designs are so different. Some are prospective studies, some are retrospective studies, some are small cohorts, some are very large cohorts. And then even when you're looking at similar types of surgery, you might have single establishment studies versus multi-establishment studies, etc. So it's quite difficult to get an idea, but we know that it varies. And usually what we say is that certainly for orthopedic surgery, you can expect that roughly 25% of patients are expected to experience chronic pain. So that's pain that goes beyond the 12-week period of initial tissue healing, along with the treatment, anti-inflammatory treatment. So the incidence of chronic pain in animals could well be high and could well be associated with conditions that we don't usually think of as being associated with chronic pain, such as neutering, etc. I should also say docking, but we're going to come on to talk about docking a little bit later. Docking and ear cropping. Yeah, I'm appalled to see that ear cropping is becoming much more common in this country now in the UK. I know for those of you joining us in some other countries, you have ear cropping already, but until I would say about 5 years ago, I'd never seen a cropped dog in the UK, and now I see them, yeah, every time I go for a walk. Okay, so let's look at the factors associated with that risk of developing chronic pain. So what could those factors look like? So we've essentially got factors that fall into three categories here. So we've got the genetic component. So that's associated with your species, your gender, to some extent your breed, your genotype, and your epigenetic profile. Then you've got environmental influences, and these are vast. So you've got environmental influences such as early life experience, stressful events. You might have prior injuries, prior diseases. You could have, that includes different life stages, so different vulnerabilities for the development of chronic pain, etc. And then you've got your immediate environment. So, you know, what are you fed on? What's your exercise regime? Are you having your needs met? Are you socially isolated? Are you part of a social cohesive group? Are you part of a social group that isn't cohesive, etc.? So all of those things. And then obviously you've got the interaction between genes and environment, which is the all critical bit, right? So that's the bit that contributes to personality, psychology, and particularly contributes towards things like optimism, pessimism, and yes, animals can be optimistic or pessimistic, to background levels of anxiety, to different reward biases, so what the reward profile looks like for the animal. So what do they find rewarding, what do they not find rewarding, how rewarding do they find rewarding things, etc. You can see some terminology there that's a little bit odd for veterinary medicine. So catastrophization, we don't know whether animals catastrophize. I used to think that they definitely didn't have the capacity for catastrophization. But actually, the more we discover about cognitive function in animal species, the more it becomes likely that certainly some species have the capacity for catastrophization. And the other thing is that I'm always reminded of cats. So anyone who's ever had experience of cats that are hospitalized, very often cats can deteriorate physiologically. They look like they're in a huge amount of pain. They stop eating. They get sicker and sicker and sicker. And for all intents and purposes, look like they're going to die. And then a very helpful veterinary nurse comes along and says, you know, let's cuddle the cat. Let's stroke the cat. I'm going to sit here in my lunch hour every day and stroke the cat. And sure enough, they start eating. They perk up. They don't look miserable anymore. And they're ready to go home and they're perfectly okay and don't need any analgesia. So it's a really good lesson on lots of different levels, and I'm very glad that I was lucky enough to work with some really good nurses early on in my career, so I learnt that lesson really on in my career. So it's a good lesson on lots of levels. One of the levels is that clearly our social interaction interaction with animals makes a huge difference to their physical well-being and can impact on their pain perception and appetite and all of those things that keep them well, etc. But also, potentially, is that a form of feline catastrophization? It's possible, right? And we don't know yet, and we don't have cognitive testing in cats that is complex enough for us to be able to identify that. But it's certainly one of those examples in the back of my mind that I think could be associated with catastrophization. But essentially, what we're talking about when we're talking about catastrophization is that pessimism versus optimism. And we know that pessimism versus optimism is hugely influenced by your reinforcement history. So this again is where we have to have that network of professionals working together, because the veterinary surgeon can identify pain, can diagnose pain and can treat pain. But what they don't have a handle on, because they're not working with the dog in the real world, is they don't have a handle on the reinforcement strategy, on that ability to be able to modulate the optimism, pessimism using different reinforcement strategies and using different behavioral modification techniques. And we'll come on to some examples a bit later. Now, if we look at environmental influences, we can essentially divide those up into three categories. So we've got innate mechanisms. So that's essentially how that individual is physically made up in terms of epigenetic influences. Pain can both induce epigenetic changes, and epigenetic changes can leave the animal vulnerable to the risk of pain. Then we've got acquired mechanisms, and this is where the animal may have had an injury or an experience of pain previously, and that actually primes the pain network to be hypersensitive to injury in the future, disease or injury in the future. So you end up with a pain network that is silent whilst the animal doesn't have another injury or disease. So let's say, for instance, we take neutering as an example of an injury. So early in life, the animal's neutered, that's an acute injury. That could potentially be, if the animal isn't given sufficient analgesia, and I'm sorry to say that we're still in a position where animals are not given sufficient analgesia for neutering. But if the animal's not given sufficient analgesia, the animal can recover from that, and they do very well. Even when given very little analgesia, they recover very well from neutering and appear perfectly normal and not have chronic pain associated with that. But the pain network has then been primed so that when the next disease or injury comes along, the animal is hypersensitive to that pain, so the intensity of pain and the pain experience is worse, but also the risk of developing chronic pain is much, much higher, and that's called priming. Now, the third category when we're thinking about environmental influences is brain vulnerable networks. So that's looking at which networks in the brain might be, the changes in those networks might be associated with the risk of pain. And we'll come on to talk about that in a little bit more detail, because it speaks to the pessimism, optimism conversation we were having. Oops, for some reason, I can't change the slide. That's because we've got strange. Oh, okay, that's because we've got animations. So yeah, oops, let me go back so that I can make sure you get the benefit of those. So we've got genetics, epigenetics, we've got life experience and priming, and then we've got reward network and descending inhibition, which we're going to talk about in a little bit. So those three categories, and we're now going to go through those in more detail. And some of this will be recapping from the previous lectures, but presented in a slightly different way. That's not a mistake, that's on purpose. So we're getting the information, but from slightly different angles, so that hopefully it's helping to build that jigsaw puzzle in your mind and put everything into context and see how it all fits together. So in terms of genetics and epigenetic profiles, we've obviously got genetic sequences, and there can be alterations to the genetic sequence that actually leave the animal at risk of developing chronic pain and or leave the animal at risk of developing painful conditions. But even if they don't leave the animal at risk of developing painful conditions per se, when those conditions occur, those hardwired changes in genetic sequence can then mean that that animal is predisposed to developing chronic pain. And that could underlie some of the breed differences that we see in the response to painful conditions. So this idea that some breeds are stoic and some breeds are hypersensitive, that could actually be the case. That might not be behavioral stoicism, as in the animals behaviorally masking the pain. It could actually be that the genetic sequences in those breeds leave them less at risk from experiencing pain in that way, either acute pain, as in the intensity and pain experience, or the risk of developing chronic pain. But those are hardwired, so those are genetic sequence changes or genetic sequence variability. And these examples here are human examples; they're not animal examples. However, there is research in animal models, so I'm just using this because it's a particularly nice graphic from Denk et al. Now, we can also get epigenetic changes, and these epigenetic changes can occur locally at a particular genetic loci. So you can see here methylation occurring at this particular sequence here, or methylation occurring at this particular sequence here. So they're epigenetic changes because they're changes that are occurring at that particular location, sequence location. Or you can get epigenetic changes that occur globally. So an early life experience trauma could have an epigenetic change associated with tissues in the amygdala. And that would change the way that the amygdala communicates with the prefrontal cortex, or the way that the amygdala communicates with the insula, which is another brain area that is part of the pain network. If you're joining us having not seen the previous webinars, you can go back and look at the previous webinars, and we talk about the pain network, which is a network of brain areas that are all active when an animal is in pain. So these global changes can actually occur across the pain network, so potentially in all of the areas that are involved in processing pain within the brain, or they can occur in particular areas, so the amygdala, the prefrontal cortex, the insula, the striatum, etc., etc. So epigenetic changes don't just occur across the board in the entirety of the body. You've got a lot of detail there that can mean that they may only change the sensitivity. They may only change the sensitivity in particular tissues. They may only change the sensitivity in particular receptors. Or they could change the way that the brain is processing the pain information to upregulate or downregulate, or to increase the experience of pain, decrease the experience of pain, etc. And the example there given is lumbar disc disease, which is probably most relevant to our Daxies or long-backed dogs. And actually some of the brachycephalic dogs are also prone to lumbar disc disease. Now, we also have inflammatory or neuropathic pain changes associated with another type of epigenetic change. So we were just talking about methylation, DNA methylation. But here we're talking about histone modification. So it's a different type of epigenetic change. And these types of epigenetic changes can be associated with inflammatory pain and neuropathic pain, and changes in the way that the body processes those. And what's interesting about histone modifications is that although we've got less data associated with those and pain, we do see with histone inhibitors or histone modification inhibitors, so they actually inhibit the process of histone modification, we see analgesic effects in animal models, animal models of chronic pain. So this is a way of actually manipulating the epigenetic changes so that we're not just dampening down the pain. So, you know, we used to think of painkillers in terms of killing the pain. That's why they're called painkillers. But of course, this is actually potentially undoing some of those epigenetic changes. So you're not simply stopping the brain from recognizing the pain, you're also changing that wiring change. So these are interesting in terms of, these are called HDAC inhibitors, and they're an interesting potential drug target for some of the newer drugs. Okay, now if we think about that second component of environmental factors that increase the risk of pain, life experience and environment, and we talked about priming there. So where we have an adverse event, so that might be an emotionally traumatic event, or it might be a physically traumatic event. So it could be disease, injury, or an emotionally traumatic event. That can then lead to epigenetic changes. It can also lead to changes in cell biology. So that's across the board in all cells, but how cells are actually made up and how they function. And then they could also lead to systems and neural network changes. And we talked about that a little bit in the previous lectures, the previous examples. Now, the epigenetic changes are interesting because life experience and environment can lead to epigenetic changes that predispose to depression and to mood changes. And those changes in mood and depression and anxiety that we were talking about, for instance, last week when we talked about pain and anxiety, then become a risk factor for chronic pain. And one of the ways they become a risk factor is persistent alterations in histone methylation. So that's persistent alterations in the epigenetic changes that we were previously talking about, but also in things like brain-derived neurotrophic factor. So brain-derived neurotrophic factor is an incredibly important factor. And it's important for neuron development. It's also important for neuron change, for synapse development, synapse change, dendritic changes, so the change to shape of neurons, etc. And we know that the development of chronic pain involves the changing of the structure of neurons. And one of the ways that that occurs is brain-derived neurotrophic factor. So the fact that epigenetic changes associated with adverse events and life experience can lead to persistent alterations of brain-derived neurotrophic factor promoters means that that's a direct link to the change to the structure in the neurons. And then that goes on to predispose to chronic pain, because we know that chronic pain is associated with changes in the neuron structure. So you can now see that although we're coming at this from a slightly different angle, it's fitting together with what we already know about the changes associated with chronic pain. But you can also see that we're starting to develop this vicious cycle where chronic pain can lead to changes, epigenetic changes and changes in mood, etc. And mood can lead to epigenetic changes and changes in pain, etc. Now, in terms of cell biology, you can, let's say, for instance, you have repeated challenge with an inflammatory mediator. So that could be if you've got a hypersensitivity to a dietary component. So we see this in some ways anecdotally, although there are some papers that suggest a link has been identified, but we certainly see it in a high number of cases anecdotally, where you get chronic gut disease or chronic skin disease associated with chronic pain. And that's because you've got repeated challenge of an inflammatory mediator, and essentially that changes the inflammatory profile for that animal, and that changes the way that the cells process information, because that chronic inflammation, which becomes a chronic systemic inflammation, then changes the cellular processes, so the way that those cells communicate with each other, and actually the way that the cells process energy within the cell, so energy production and communication with other cells, etc. Now, this is what contributes to priming. So that process that we talked about earlier, where you can get a seemingly unrelated event that then predisposes to chronic pain with a later event. And this is one example where this mechanism plays into that. So the epigenetics can play into this, but so can the cell biology. So, for instance, you can have a painful event represented here with the grey. So this is in a naive animal. So in an animal that hasn't had a significant painful event previously, they'll, in response to, let's say, I don't know, what painful stimulus should we say? in response to being run into by another dog in the park. That seems to be my only example. I must think of some better examples. Oh, I don't know, treading on a sharp stone, that's probably a good example. You'll have a certain level of intensity and it'll go on for a certain amount of time. However, if that animal has been primed with a significant adverse effect in its early life experience or environment, then the animal experiences exactly the same stone on the feet with a higher intensity and more prolonged time. So that's the same effect that we've been talking about previously, but now we're looking at it from a cellular component level. And that's because the cell biology changes lead to this effect called priming. So everything's kind of adding up here to explain why we see those changes. Now, in terms of systems and neural networks, the example here given is a neonatal skin incision, and they give this example because it's commonly used in rodent research as an example of a known painful stimulus in the neonatal phase. However, it's quite interesting because it's directly relevant to docking and to ear cropping, and we have data already for docking in a number of different species, so pigs, sheep, and I believe there's a paper in dogs as well, looking at epigenetic changes associated with that, so the induction of early onset genetic factors, but also looking at the change in cytokines that are associated with epigenetic changes. And in this example of the neonatal skin incision, you get altered innervation of the skin and spinal cord, and you also get altered glial responses. So what do we mean by that? Well, all that means is that what we're seeing altered innervation of the skin. So we're seeing an increase in the number of neurons that are supplying the skin. So that's like a version of hyperalgesia or hypersensitivity. And then we're also seeing changes in the spinal cord. We talked about those right in the first lecture when we looked at the changes that occur within the spinal cord associated with chronic pain. So you get those changes, and you also see altered glial responses. And the glia are the cells that wrap themselves around the neuron, and they're really important for how the neuron communicates with other neurons and also for how the cell functions within its network. So those lead to altered pain sensitivity in adulthood. And what's interesting about the docking literature is the docking literature has shown increased pain sensitivity in lambs that are docked. So an increased pain sensitivity that isn't the tail, it's a generalized increased pain sensitivity. So you won't necessarily notice it in the individual because they'll be just as sensitive on the tip of their tail as they will anywhere else in their body. But if you compare that individual to a non-docked individual, they'll have a different pain sensitivity. The effect sizes aren't huge, so you don't necessarily see obvious clinical signs associated with this. But when you look at a large number of animals and you compare them scientifically with all other things being equal, you can see group differences between those docked and those not docked. And bear in mind that docking appears to be a lot more simple procedure, straightforward procedure, and less painful than ear cropping. And that's perfectly logical because ear cropping is associated with an ongoing pain condition. So ear cropping is a potential animal model for the development of chronic pain, sadly enough. And yeah, I guess at some point we'll probably look at that because it would provide even more evidence that we shouldn't be cropping dogs' ears if we need it. Okay, so to stay on early life experience and bring in some of the stress response information that we've been talking about, let's look at how the early life experience relates to that. So the HPA axis is the hypothalamic pituitary adrenal gland axis. So that's the hypothalamus in the brain, pituitary gland at the base of the brain, and the adrenal gland on the kidney. And that's the communication axis, which is essentially known as stress cycling. So that's our HPA axis is for stress reactivity. So our response to stress. So that's emotional stress and physiological stress. And what we see with traumatic early life experience, and that's both physical trauma and psychological trauma, is that we get changes in the HPA axis that lead to decreased glucocorticoid receptor binding and increased levels of CRH and ACTH. So both of those, CRH is responsible for communication from the hypothalamus to the pituitary, and ACTH is responsible for communication between the pituitary and the adrenal gland. So you've got increases in both of those, which is responsible for what we call an increase in stress reactivity associated with traumatic life experiences. Now, unfortunately, pain is also associated with changes in stress reactivity. So again, it's another example of this vicious cycle, which explains why things get out of control and aberrant behaviours can develop associated with painful conditions that don't necessarily appear to be that painful. Now, the other thing that happens with traumatic early life experiences is you get changes to monoamine neurotransmitters. So monoamine neurotransmitters are things like serotonin, adrenaline, noradrenaline, dopamine. So all of those neurotransmitters that are responsible for how your nervous system functions. And a traumatic early life experience disrupts those neurotransmitters. So you can get increases and decreases in sensitivity to those neurotransmitters, and also disruption in the processing of those neurotransmitters. So increases and decreases in receptor densities for different transmitters, but also different receptors. So serotonin, for instance, has several different receptors. And depending on the effect of the early life experience, which depends on the early life experience and the genetic and epigenetic profile of the individual and the environment of the individual, etc., you can get different changes either at the receptor level or the protein level, or to the way that that whole neurotransmitter system works, or indeed to multiple neurotransmitter systems. And this is one of the reasons why tricyclic antidepressants can be an effective treatment for chronic pain. And that's because of these monoamine neurotransmitter disruptions, and tricyclic antidepressants specifically treat for that. And we're not going into pharmacology and treatment for pain in this particular series. We're going to be doing that in the first half of 2023, but this is providing the groundwork for that series, looking at different types of pain. So we know we've got inflammatory pain associated with acute pain, etc. We've got anti-inflammatories that can deal with that, and then we've got monoamine neurotransmitter disruptions, which can be associated with early life experience. They can also be associated with pain, so pain itself, and that's again why we get this vicious cycle. So yeah, different classes, and then we've got other classes of drugs that we use for chronic pain that affect the remodeling of the nervous system, for instance. Now, the other physiological effect of traumatic early life experiences is this change in pro-inflammatory profile. So you get a microglial activation, and microglia are those cells that surround the neurons that are incredibly important for how they communicate, and you get an increase in cytokines. So those cytokines are how the different cells communicate with each other, and they affect a whole range of different metabolic processes. And the pro-inflammatory profile change is predisposed to hypersensitivity. So that's related to acute surgical trauma, such as docking, ear cropping, potentially neutering, etc. So another reason why it's so important that these animals get analgesia. And I'm pleased to say, you guys can chip in the chat, but my experience is that it's now kind of expected that animals that are being docked and ear cropped would receive analgesia. But certainly when I started out as a vet, it was routine not to give them any analgesia. But hopefully we've got that message through. There certainly is enough science out there to mean that vets should be using analgesia. Okay, your second secret word is pool, as in swimming pool, pool. Now, we talked about vulnerable brain networks being that third category for environmental risk factors associated with chronic pain. And you may remember this diagram from our previous lectures. This is from lecture 1, when we talked about the pain network. So this shows the different brain areas that are involved in processing pain and how they're connected to the spinal cord and then to the sensory. In this case, this example is the skin. So that's the pain network. Now, when we talk about vulnerable brain networks, we're not talking about the pain network, but we are picking out networks that have commonalities with the pain network that explain why the changes in those brain networks leave you vulnerable for developing chronic pain. So for that, I want to look at this, this graphic here, which is in the same orientation as our pain network graphic. If you didn't come to the previous lectures, don't worry, you can go over those in the recordings and go over the pain network in some detail. But essentially, when we look at vulnerable brain areas, it's quite simple to overlay on top, because we've essentially got 2 broad categories. I mean, we've got other areas as well, which are in this salmon coloured pink, which also appear within the pain network. But these 2 broad categories are thought to be particularly important for the vulnerability to pain, and changes in these networks leave the individual with a high risk of developing chronic pain. And this is incredibly interesting from our point of view, from a veterinary behaviour point of view, from a behaviourist point of view, from a dog training point of view, and indeed from an owner's point of view, because by far and away the one that we have the most evidence for, I'm going to now talk about them in a different order. Okay, rewind that sentence. Let's talk about reward network in a minute. So we'll talk about the descending inhibition pathways. So those are the pathways that send signals back down to the spinal cord to change the way that the pain is being processed, and to either decrease the pain perception or increase the pain perception, decrease pain processing, increase pain processing. So this is the descending pain modulatory system, DPMS. And we see differences in structure, connectivity, so not just the structure of the different areas within this network, but the connectivity of the different brain areas within this network, functional changes and neurochemistry changes, so those monoamine changes, but also other chemical changes within that network. And though any changes within that network associated with structure, connectivity, function, neurochemistry can increase the risk of developing chronic pain. Changing the nociception, so changing actually the way the body responds to the initial insult, the initial pain inciting thing, factor, and also leaving the animal hypersensitive to pain. Now, this second network, there is far more rich data in humans related to this second network. And this second network is the reward network. And this is the network that I think is super exciting, because it explains why behavior modification can influence pain perception, and essentially why chronic pain in humans now is actually primarily, not primarily, it's an extremely important part of the treatment of chronic pain is to look at psychological interventions. So changing essentially from a pessimistic to an optimistic brain, looking at decompression, looking at increasing value, increasing enjoyment in life, finding hobbies, etc., that bring enjoyment. And those things are particularly important because changes in the reward network directly relate to the vulnerability or risk of chronic pain, and also to the way that the brain processes pain in the here and now. So changes to the reward network might be changes, so there might be differences in structure, connectivity, function, and neurochemistry, so exactly the same as the descending pain modulatory system. So any changes associated with the reward network, that leads differences in structure, connectivity, function, and neurochemistry. And guess what leads to changes in those things? Training, interaction with the animal, social network with the animal, how the animal's treated, how compassionately the animal's treated. All of those things are going to change the structure, connectivity, function, and neurochemistry, because they all lead to neuroplastic changes. And this is where I'm going to say that training method has a huge impact on these changes in structure, connectivity, function, and neurochemistry. If you're training with reward-based methods versus aversive methods, we don't go into the neuroscience of punishment in this lecture, although it will be coming up later in the year, you're going to have different changes to the structure, connectivity, function, and neurochemistry. So that's before you have the chronic pain developing. But that can then lead to a higher risk associated with the development of chronic pain. And that leads to things like changes to the valence of reward and adversity, which we talked about last week in association with anxiety, because of course anxiety is associated with a change to the valence of reward and adversity. And pain itself is associated with a change to the valence and reward and adversity. So you've got these cycles that just keep feeding each other and feeding each other. And we need to break those cycles with behavior modification and or pharmaceutical intervention. Anhedonia, which means I don't enjoy anything. So that's where you get an animal that lies around looking depressed. Change to coping style. So when we're talking about reactivity, this explains why you can get that shift in coping style from a passive coping style to an active coping style, or from an active coping style that was hyperexcitement to a reactive coping style. So both of those are still active coping styles, but a shift in coping style. And a change to social interactions. So in terms of reactivity, the social environment in the outside world now isn't the same. And it isn't the same because you've got this change in reward network. It's led to an increased risk of chronic pain, and it's circling back to change the social interactions and the way that your brain processes social interactions. So the idea that an animal can become reactive to other dogs in the park, whereas it wasn't reactive to them before, is perfectly logical when you look at what's happening in terms of change in the social interactions, because you've changed things within the reward network through this vicious cycle. Now, one of the most impactful statements in the Denker et al. Paper, which I took those graphics from, is it seems likely that transition to a continuation of chronic pain is dependent on the state of motivational learning and reward circuitry of the brain. So this means we can potentially influence the risk of animals developing chronic pain, and the risk of animals being vulnerable to the duration of chronic pain and the intensity of chronic pain through behavior modification. So through changing the motivational learning and the reward circuitry of the brain. And that's incredibly important. And this is a review. So this is multi-layered research looking at fMRI, structural MRI, looking at behavioral studies, at nociceptive models, at animal models and human models. And this is in their conclusions. So really, really important for us, because it really explains how key behavior modification is to the pain profile. Okay, we're on the downhill slope now. So let's look at the integration of pain behaviours. And essentially, to look at the integration of pain behaviours, we need to think about things in terms of two systems. So the physiological systems and the psychological systems. The psychological systems we've been through in some detail, looking at emotional changes, cognitive changes, changes in attention, changes in learning and memory, changes in perception, so that's perception of pain, but also perception of reward and environment, etc., and changes in motivation associated with that reward circuitry. Now, physiological systems are things like the sleep-wake cycle. So sleep is incredibly important for how we perceive pain, but also how we process pain. The endocrine system, so the HPA axis that we've been talking about, and stress reactivity. Sensory function, so how are other sensory functions, and this explains why pain can be associated with changes in sensory functions, so noise sensitivity, etc. Immune changes, and some of those early life traumatic experiences will be having effects on the immune system and the pro-inflammatory profile of the animal, and therefore changing the pain perception and pain processing, etc. Motor systems, how effective and functional they are, and autonomic systems such as diet, etc. So those are physiological systems, and together with the psychological systems, they integrate together in neural networks to produce the aberrant behaviours that we're seeing associated with pain. So we've gone through 4 categories of them in this series. It's not an exhaustive series, but we've gone through aggression, arousal, anxiety, and reactivity today. But they're just examples of aberrant behaviours associated with pain. But those aberrant behaviours come from the neural network changes associated with the integration of physiological system changes and psychological system changes. They're not coming out of nowhere. They're not coming out of thoughts that are coming out of nowhere. They're coming out of those changes: epigenetic changes, environmental changes, changes of function, structure, neurochemistry, etc. And we know that now, right? Because we've had all of that information throughout the 4 lectures. And this is like, this graphic for me is so exciting because it brings together everything that we've been talking about, and it whittles it all down to what we're interested in, which is the aberrant behaviours that we're seeing that are associated with the pain. So just to go over sleep, because we haven't talked about it in other sections, and it is incredibly important for pain processing. If you don't believe me, when you've stayed at, if you're a vet, wait till you're on call and you've had no sleep all night, and then prick yourself with a pin, and you'll be able to notice the effect size is huge. You will notice that it's very much more painful than it would be normally, particularly normally when you're relaxed on holiday enjoying yourself. The one that always gets me is stubbing my toe. So if I haven't had any sleep, if I've been up all night on call, or you know, up all night with the dogs or whatever, and I stub my toe, it's unbelievably painful, excruciatingly painful, as compared to when I'm fully rested. So sleep has a really big effect size on pain processing. And essentially that's because it has a really big effect size on tryptophan and serotonin production. Tryptophan being one of the components that is needed for serotonin production. Serotonin is a monoamine neurotransmitter and incredibly important in pain processing. But sleep is also important for emotional regulation, and that's because without sufficient sleep and with disturbed sleep, you get that change in coupling between the brain areas. So you get that change in synchrony and communication between the different brain areas. It's also important for consolidation of memory, and that might not be thought to have a direct impact on pain, but actually it can have a direct impact on pain because it can change the way that you consolidate memories and what you consolidate them with. Because sleep is needed for consolidation. If you don't have sleep, you don't consolidate the memories that happened before that until later when you do have sleep. And by that stage, you've already had lots of other experiences that may then get consolidated with them. And that's how you end up with negative associations. And within that time, you've potentially developed anxiety associated with the pain, and catastrophization potentially associated with the pain, etc. And then by the time you sleep, you're consolidating all of that associated with the painful situation. Sleep's obviously needed for metabolic waste clearance. And if you don't have sufficient metabolic waste clearance, that will impact on the way that the monoamine neurotransmitter system functions, and therefore on the development risk factor for development of chronic pain. And immune system's exactly the same. And then obviously cognition. We didn't talk about diet in any great detail, but it is interesting that there's a fairly new paper in 2022 titled Chronic Pain in Dogs and Cats, Is There a Place for Dietary Intervention with Microphenolamides? I didn't say that very well, did I? But you can read it there. I'm not going to go through that paper in much detail here because we haven't really gone into diet in much detail, but I do talk about pain and diet in the microbiome webinar that we did previously. That's a single webinar that I think is still available. Bobby can probably put the link in the thing.
It is available on our website. I'll put the link in the chat now.
Yeah, so just to avoid repetition for those of you who may come to all of those webinars, but it's actually a really nice paper. It's written really nicely. It's got some really interesting stuff. It goes into a lot of the pain biology that we've been talking about. So it looks at the systems and things like coupling between different brain areas. So it's actually a really nice paper if you've enjoyed this series to read at the end of this series, because not only does it help to go over that information written by a different author, because that's how we learn, is repetition with slight twists on everything, and because it is so neuroscience centric, it's quite a nice paper for that, but it does also lead into into the question of dietary modification for changes in pain. And there's obviously a link there to microbiome and how microbiome can change the way that we process pain. Now we're rounding up. So if we just look at the last couple of slides, behavioural consequences of pain in terms of behaviour integration. So if we look at animals that are in chronic pain, and this might not be chronic pain that's obvious to us, we see a whole load of changes associated with that. So perception, cognition, attention, emotion, learning and memory and motivation. So those are all the changes that we've gone through in various different elements previously. But then if we look at the behavioural consequences of that, it becomes very obvious why you can get changes to reactivity associated with pain. So you've got inattention, and if you're inattentive, then things can appear out of nowhere, so you're more likely to be reactive to them. But also altered size of perception, so it can appear like a dog running towards you or a person coming towards you is much larger in reality than it is, or is much faster in reality. So that's called changes in perception. So when you're in pain, those objects within the environment become extremely salient, and actually there's now scientific proof that the size of those objects within space become visually bigger, which I know is like absolutely amazing. But so that's the change in perception associated with chronic pain. Cognitive deficits. So if you have cognitive deficits associated with chronic pain, you're much more likely to be reactive. Why? Because you can't think through what an appropriate response is beforehand. So you get caught unawares and you're more likely to be reactive. Hypervigilance is obviously going to make you more reactive. And then we get a reward deficit state, depression, heightened anxiety. Well, all of those could lead to a change in coping strategy, which could mean a change towards a reactive coping strategy. Memory deficits, fear learning. Fear learning is affected by chronic pain. So you create stronger fear memories when you're in a state of pain. And what a stronger fear memory is going to do? Increase your reactivity when you're put back in that situation again. And changes to motivation, you get decreased levels of goal-centered, oriented behaviour and altered survival salience. So those are going to change the way that you cope with the environment around you and may well lead to a change in coping strategy. And all of that is brought together by a really nice graphic, which is in Simons et al. 2013, which touches upon the resilience conversation that we started having last week when we were talking about anxiety and how lowered resilience can lead to changes in pain processing, but pain also decreases resilience, and therefore why it's so important that we do use behavioural modification techniques that are supporting healthy resilience, both in terms of prevention of risk for chronic pain, because animals with higher resilience are less at risk of developing chronic pain, and in terms of treatment of painful conditions. And, you know, if the animal has been physically examined and the vet's sure that it isn't pain, but you think there still could be pain, what can you do about it? You feel hopeless. You're not hopeless. You can do behavioural modification program, which focuses on building resilience, because we know that building resilience reduces the risk for chronic pain and the experience of pain when it's there. So there are things that you can be doing whilst you're then trying to find a vet who you might want to work with to maybe have the animal re-examined or second opinion, or a veterinary behaviourist who has a particular interest in pain. And we know that there are lots of them because they're on this webinar. We should probably do a networking function at some point, Bobby. I don't know how we would do that, but it seems like we should be putting vets who are interested in pain in touch with behaviourists and trainers that want to work with vets in that way.
What a great idea. I will write it down.
Yeah, write it down, because we have terrible memories. So why am I talking about resilience? Well, let's look at the bouncing ball analogy. So here we have a bouncing ball. Let's just say it's a tennis ball. Literally, it's a ball. We're not analogizing right now. And a bouncing tennis ball, when it bounces the first time, will reach a height of 1. When it bounces the second time, reach a height of 2, which is lower, 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 until the ball is still. So that's normal bounce to no bounce. Now, if we look at that now as an analogy of systems function, so physiological systems and psychological systems, remember that resilience is all about the physiological systems, stress reactivity, HPA axis activity, so hypothalamic, pituitary, adrenal gland axis activity. So systems function, we have normal function is the ability to be able to bounce and then bounce back up. So that's normal function. But as we get deteriorating function, we get less of an ability to bounce back up to normal. Here, that height 0 is normal. So we're less resilient and less able to recover. Whatever the system is less well able to get back to that normal level. So if we're talking about HPA activity, HPA axis activity, then the ball is less well able to reach baseline, naught being baseline. So as we see systems, as we see this change in bounce, so the change in ability to get back to baseline, we see the systems function deteriorating until we've got abnormal systems functioning. So abnormal physiological systems or abnormal psychological systems. And we said both of those systems integrate to eventually cause aberrant behavioral changes. So here we see a healthy individual who has high resilience and high bounce, the ability to bounce back to normal, healthy brain function. Here we see an animal that's had an injury and you get sensory changes. So you've got lowered resilience, less bounce back, and you get sensory changes, but that animal can still be treated, and it can be treated for pain pharmaceutically, and it can be treated with behavioral modification, but it should still physiologically respond to that treatment regime. Now, if the consequences of the injury continue, either because the animal doesn't receive appropriate treatment or because the inciting cause is continuing, you get psychological changes. So this is where you're going to see the behavioral changes. This is where your classification of behavioral patients is going to present to a veterinary behaviorist or present to a behaviorist for problems associated with underlying pain that's been unrecognized. But those psychological changes to start with would still be where there is some systems function. So there's some systems function, but it's reduced, and those animals should still respond to appropriate treatment. So we need to get the treatment in quickly. Why? Because if we don't get the treatment in quickly, then the systems function will continue to deteriorate, but the animals still should respond, should have the physical ability to respond. Now, if that condition continues to deteriorate, we get maladaptive changes, and this is where we're sitting between the potential for treatments to work and the potential for some treatments to be, for the animal to be resistant to some forms of treatment. So it gets harder to be able to choose a treatment protocol, whether that's a drug protocol or a behavior modification protocol, that's actually going to modify those maladaptive changes. And if the animal continues to deteriorate further, we get what we call system failure. And system failure doesn't mean that the animal dies. It just means that it becomes resistant to the treatments for chronic pain. So you may well have permanent maladaptive behaviors, so permanent aberrant behaviors associated with that because of a resistance. Or you may be able to modify the some behavioural components associated with that, but still have some propensity for chronic pain, or still have some chronic pain there. Sometimes what it means is that we get a resistance to certain classes of drugs. And that's why pain trials at this end, when the animal's already had a problem that's been going on for some time, can be really tricky, because trying to find drugs that the animal's going to respond to is really difficult. So how does that help us? Well, this is a graphic which is very human-centric, so it doesn't directly relate to animals, but I still think it's quite useful, because what this graphic shows us is that we get changes within the brain, which we know about because we've been talking about them for 4 weeks now. So in all the different brain areas, they lead to psychological functional changes, which we know about because we've been talking about them for the last 4 weeks. And they lead to an opening for psychological treatments. Now, a lot of the psychological treatments there won't be relevant for dogs or for animals. Some of them will, but some of them won't. But if we think about the psychological treatments that we do have access to, resilience conditioning, resilience is incredibly important for these cases where pain is suspected. Olfactory motivated activities, so that's your scent work, your snuffle mats, etc. Reinforcement strategy modification. Reinforcement strategy modification is needed because of that change in pain and pleasure, in reward and adversity. Relaxation protocols, pattern games, etc. And those are probably equivalent to things like yoga and mindfulness and those other psychological interventions that we use for humans. And this brings us to the conclusion of all 4 weeks, which is don't wait to see if it gets worse. Treat pain early if you suspect pain. Now, obviously, you can't give drugs if you think there might be a negative impact of drugs. So you can't treat with a non-steroidal anti-inflammatory if the animal has gut disease or kidney disease, etc. Those are conversations to be having with the veterinary surgeon. But you just need to look for other treatments, because treating early is incredibly important. Treat early because by the time you have behavioural change, which presumably is the direction that you've come in, the animal's presented for behavioural change and now you're thinking that pain underlies it, the animal's already developing maladaptive changes. And you saw on that diminishing graphic there that you've already shifted over to the right hand side and you're already shifting towards the stage where the animal will become resistant to intervention. So it's really important to get in early and don't just see how the patient goes and then think, oh well, we'll go back and treat for pain later if it doesn't get better. If you've got reason to suspect that there's pain there and you've got a veterinary surgeon on board who is happy to support a pain plan for that animal, then early treatment is really, really important. Thank you. And we've still got time for questions.
Okay. So interesting. The sleep conversation always blows my mind. Even though you and I have had so many conversations about it in general and how to use sleep in a way to like part of your behavior modification program, especially when you're resilience conditioning and the timing of the sleep, right? I can actually take my young dog and say, okay, we had an amazing experience and now I'm going to put you in the car so we can leave and you could go to sleep.
Completely. Yeah, absolutely.
It's amazing.
Yeah, and so undervalued. And I think quality of sleep is so undervalued in our pets. And I wonder actually how many of the patients that are presented for behavioural difficulties, we actually just need to look at their sleep profile, because we know from human data, we also know from animal data what detrimental effect it has. So yeah, incredibly, incredibly important and so well connected to the gut, to the skin, because that's another inflammatory profile, but particularly to the gut and particularly to pain processing.
Okay, we have a few questions. For those of you who signed up for the Pain Rewires the Brain series, you'll get access to the webinars. If you haven't received access to the previous ones, you'll get them all together in an email that's going to go out in the next few days. It's going to include this recording link as well as all of the recordings. So don't worry, you'll get them really soon. All right, this question's from Vanda. It's a long one, so here it goes.
Okay.
I've been thinking a lot about police dogs and that they go through a lot of pain and trauma during service. When people say these dogs want to work as police dogs, their reason is that these dogs enjoy what they do. Now we know the role that dopamine plays in wanting something that is not good for us. Oh, so many thoughts about this. Can we say that these dogs seem to be liking what they do because of the dopamine? Well, obviously it's all a very unhealthy environment for them, both physically and mentally. Or they might not be enjoying what they actually do. How can we effectively advocate for these dogs from a veterinary behaviorist perspective? Thank you.
So the answer to the first part is yes, and you hit the nail on the head, because these dogs, termed high dopamine dogs, are motivated to do their work. They're not necessarily enjoying it. There's no evidence to say that that's associated with enjoyment. It's just that previously, before we knew better, we used to make a direct correlation between motivation and enjoyment. But we know very clearly from the neuroscience literature and from the psychology literature that the two things are different. And the example that I usually give is the drug addict is very motivated to climb out of the window and go and score drugs, even though it doesn't feel good, and they know it doesn't feel good, and they also know on a whole load of levels that it's really bad. So motivation and enjoyment are definitely two separate things. And yes, I think it's highly likely that there are service dogs that are bred for high motivation, and they will literally work till they drop, but that doesn't necessarily mean they're enjoying it. What was the second part?
Hold on. Can we say that these dogs seem to be liking what they do because of the dopamine, while obviously all a very unhealthy environment for them, both physically and mentally?
They definitely could. And I mean, my very limited experience of service dogs, which is related to a dalliance with RAF dogs, and then obviously my own dog Raven, who is ex-police, and then conversations around Raven, is that you can't really lump them all into the same category. There are some service dogs that appear to genuinely love what they do, and some service dogs that appear highly motivated to do something which is very obviously bad for their physical and mental well-being, and there's a whole grey scale in the middle. I think the other thing about it is that they come from different genetic lineages, so you can get the really high drive military dogs that go into these incredibly traumatic environments. And yeah, I find it, there is no evidence to suggest they're enjoying it. There's no evidence to suggest that humans enjoy it. There's evidence to suggest humans are motivated to do it, and dogs. But then you also get service dogs that are bred for scent work, for, you know, working in airports, etc., who might have a completely different genetic lineage, a completely different propensity for drive, motivation, or their drive or motivation might be very much in one area but not in another. So yeah, we can't really lump them all into one category. So I don't think the message is service dogs have a rubbish deal or they have a great deal. I think the message is we cannot assume that because they're motivated to do the job that they are enjoying it. Enjoying it is separate to being motivated to do the job, and the two may be correlated or the two may not be correlated. Yeah, good. It's a very good observation or thought. And then how do we advocate for them? I think we advocate for them with the science. So, you know, not by disagreeing with handlers when they say, oh, the dog loves this job, but just by, you know, adding in a little bit of extra information. Well, how do you know he enjoys his job? And then listening to what they're categorizing as behaviors that demonstrate enjoyment, and then saying, could we say that the dog's highly motivated? Do we actually know that the dog enjoys it, or could it just be highly motivated to do it? And, you know, explaining the dopamine and the analogy with drug addiction and other types of addiction, etc. So I think it's education that helps us advocate for them. And my experience of both the RAF and the police in the UK certainly is that they're very open to this conversation, and they're very open to the conversation about well-being for their dogs, much more so than they ever were when I started 25 odd years ago. But it probably differs in different countries. So I don't know whether any of you have had kind of differing experiences with working with that category of dog. I would also put service dogs, as in emotional support dogs, into that category. I think it's slightly different because they're not necessarily actively motivated to do a task with a high level of energy, which a lot of the other service dogs we've been talking about would be, but they're actually often working very difficult conditions, and we don't necessarily know that they enjoy their life as a service dog. Doesn't mean that all service dogs have a rubbish time. It just means that we can't assume that they enjoy their life as a service dog. We have to question that and say, okay, what evidence do we have for that, and is this dog suitable for that role?
Okay, so we have a number of questions, but we only have a few minutes. So Dr. Murphy, if I could ask if folks can put their questions into, like, post them on Facebook for the most recent pain conversation that we had on our Facebook Live, would you be able to answer them?
Yes, I just need to remember to go to that Facebook.
I'll help you.
And then yes, I'll sit and answer them. If it's not tonight, it'll be tomorrow. But I'll make sure that I get through all the questions. And more importantly, if I promise to do that and then don't do that, contact me. So send me a message through Facebook or through email or through Behaviour Vets and say, "Oh, you didn't answer my question." You've paid for the series, and that means you've paid to have your question answered. It doesn't mean you can tag on 30 other questions.
Yeah.
And take up loads of my time. But if you've got questions that are posted in the chat here, you deserve to have them answered. So make sure that I do.
So the next question is from Sarah Keeker. She actually has a dog who's a patient of Behavior Vets. She's asking, what could cause a seizure when my dog becomes reactive and over-aroused, and then a painful event happens to him, falling down the stairs, hitting the step on the stairs. He immediately has a grand mal seizure that lasts 45 to 60 seconds. This has happened 3 times in the last 6 months, but not before. He's 7 years old and being treated for hip dysplasia arthritis disc disease.
Yeah. So there's no known direct correlation between pain and epilepsy. So if that was your question about whether it could be directly related to, there's no known direct relationship other than conditions that are associated with epilepsy and pain, but they would be a separate diagnosis. There's no known direct relationship between, let's say, arthritic pain and development of epilepsy. Doesn't mean that it can't occur, because of course every animal is an individual, and unless it occurs in a decent number of animals, we wouldn't recognize it in veterinary medicine, right? So that's just the way that goes. So I'm not saying it's impossible, but it's not known about, and not known about in humans either. And in humans, we have a vast amount of data. But they could be indirectly related. So clearly, if your animal stumbles, if your dog stumbles down the stairs and hits his head, hitting the head could definitely incite an epileptiform seizure. Because that is essentially disturbing and disrupting the surface of the brain. And if you've got networks within the surface of the brain that have electrical activity that just circles round and round and round, you can actually incite a seizure. So my dog Dennis, if he hits his head, he has a seizure, and he doesn't have to hit it very hard to have a seizure. And that's related to a prior injury that he had. Now, you can imagine that your dog is much more likely to stumble or hit their head if they're also arthritic. They're more likely to have longer nails that catch on the carpet. That if they're arthritic, they're more likely to stumble. They're less likely to be able to right themselves if they tread on an uneven surface, etc. And all of those could lead to a bump to the head and then to the epilepsy. So yeah, I hope that that's given you some answer to your question, if I understood it correctly.
Okay. Emily Fisher has a question. She's curious to know more about ears and tails. Why is ear cropping worse than tail docking?
So ear cropping goes through a number of different tissues, and the tissues are more sensitive. So the tissues of the ear are more sensitive than the tail, and that's to do with the innervation. You've got a lot more nerves around the head area, and that's because you're protecting your vital senses, your eyes, your ears, your nose, your mouth, etc. So you've got a lot more innervation. You've also got different types of neurons in the head and face area, which make them much, much more sensitive. So the ears are better innervated and more sensitive than the tail. Any damage to the ears also leads to a lot more neuroplastic change and the potential to develop chronic pain than it does the tail. Essentially, the animals can afford to lose their tail. It's not essential for life, it's essential for communication, but you can carry on communicating if you've lost your tail. Sure, you can carry on without your ears, but it does significantly change the way you process auditory information. And for that reason, the body makes sure that your ears are well innervated so that you protect them very well. So you've got different tissues in the ear, much, much more innervation. Cropping also is a different procedure. So tail docking involves one surgical cut and then it heals. With the ear cropping, it's a surgical cut, but then the animal also has to have the ears bandaged usually. It depends on the shape of the crop, but usually they would be bandaged, and that's associated with continued inflammation. So you get a lot, you get a greater inflammatory reaction associated with ear cropping than you do with tail docking. It's also a larger surface area, so you get a lot more inflammation associated with that. And it tends to bleed more, so it doesn't heal as well, whereas the tail, if they're docked within 3 days, tends to stop bleeding and vasoconstrict, because you've essentially only got 2 arteries there. So once they vasoconstrict, they're cut completely, at 90 degrees, so they vasoconstrict easily, so you get less bleeding, less inflammation associated with it. So it's a different surgical procedure. So yeah, ear cropping is a lot more painful than docking, and therefore needs a lot more analgesia. I mean, I'm not a fan of cropping, as you can tell. But yeah, if you do crop, then make sure that they get analgesia.
Okay, so this is a question. Hang on. From Susanna, where would allodynia type of pain be at the bouncing ball diagram? And could it still be treatable?
So yeah, we don't know exactly, and there may well be.
Maybe go back to the bouncing ball diagram real quick.
Yeah.
So people can see. I think we're going to get all the questions. There's just one more question. Actually, that's it.
Oh. Here. So for some reason my chat thing's in the way. Oh, there we go. Okay. So the allodynia develops from sensory changes, but it's a maladaptive change. Now, this is a simple diagram that shows healthy to sensory changes, psychological changes, maladaptive changes, system failure. But of course, it doesn't quite happen like that, because usually animals have a mixed pain profile, and they have a lot of different changes going on in the body at the same time, and not all the changes follow the same time course. So in terms of allodynia, there will be a time course that goes through this same process, but it won't necessarily be on the same time course as some of the other maladaptive changes. So it'll occur at a different time point dependent on the individual, which is essentially the answer to everything with complex pain profiles. So in terms of the bouncing ball, it's developing between here and here. So in theory, it should still be treatable. But of course, allodynia may well have developed early, and then the animal still hasn't been treated because the allodynia hasn't been recognised. And that's very common, because it's a difficult condition to recognise. And it's often misdiagnosed as, oh, the animal's got doesn't like having its harness on, or, you know, is grumpy when it's touched, or, you know, there are lots of ways that it can be explained away. Yeah, and to diagnose allodynia itself, you actually need to do testing, etc. So the same type of testing that they do with fibromyalgia, because it's a form of fibromyalgia, or fibromyalgia is a form of allodynia. So yeah, no exact simple answer to that question, but it should in theory respond to treatment, but it depends on how chronic it is. If it's chronic, then it may well not. It also depends to some extent on what the inciting cause is. My experience of N of 1 with my own Rottweiler is her allodynia diminished significantly once her anxiety diminished. And my own allodynia diminished over time as I got physically stronger. So I had allodynia associated with an assault and a serious neck injury, and I'm much, much less allodynic now, but that's taken 10 years or so, and a complete change to physical fitness and physical recovery.
Last question.
Okay.
This is from Sam. He says, my organization works with a lot of small dogs who are highly sensitive and defensive to touch. Is there any data literature showing trends in pain-related genetics in small dogs versus medium-large dogs?
Oh, interesting. Yeah, so I mean, we can't answer that question yet completely. We certainly know that logically there are differences in genetic profiles for the different breeds, and that there are differences in their responses to pain. The reason I said it's interesting because a lot of the small breeds have usually been bred to be closely socially associated with humans, and so therefore there would be an advantage to them having a more well-developed sense of touch. So it may well be not necessarily maladaptive, but actually just part of their original makeup, that they are more sensitive to touch. And to some extent, it would be interesting to look at breed groupings, so what they're bred for, and then to look at skin sensitivity. Actually, I've just created an experiment in my mind, which we could actually do. So,
yeah. Like you to write it down?
Yeah, I don't need to, yeah, if you just write down prod. Prod is a particular piece of equipment that we use to test sensitivity to pain. We could prod test different breeds and look at whether the profiles were different, and then prod test different breeds before and after neutering to look at whether the profiles were different.
You got it.
So yeah, there's a lot more data we need on breed sensitivities. It's also interesting because my experience, I'll be interested to know what your experience is, but my experience is that the smaller breeds can sometimes be more sensitive to other sensory modalities, so more sensitive to sound, for instance. And there is a link between pain and sound, so we don't know the extent of that link and how far it goes, but because of cross-modal modulation, you could imagine that if you're more sensitive to sound, that you're more likely to be more sensitive to tactile information or indeed to pain. So yeah, it's interesting.
Okay, that's it.
Brilliant. Thank you for all the great questions. And I've loved this series. I hope you've got something out of it, because I've absolutely loved it. And it's the foundations for everything that we need when we're thinking about pain. And I know some of you, particularly the vets amongst you, will be a little bit frustrated that I didn't give you drug recipes and stuff. They are coming. It's just that this stuff is so fundamental to understanding why we choose the drugs we do and why we treat for as long as we do and when we do, etc., that I just didn't feel that we could do that topic justice until we'd gone over this information. So yeah, it's coming.
Wonderful. Thank you so much. This webinar series will be available for sale on our website, so feel free to share with your friends. Because you guys signed up ahead of time, you got the tickets ahead of time, you got a lower price point. So we're very grateful. It allows us to keep doing what we're doing and offer free content for those who cannot afford our services. And just get more information out there in general. So we appreciate you guys spending your dollars, your hard-earned dollars with us.
Yeah, thanks for joining us, guys.
And thanks so much, Dr. Murphy, for doing this incredible series and teaching us so much about pain and behavior and how it literally rewires the brain. It's bananas.
You're very welcome.
Take care, everybody.
Bye.